Hello friends, welcome to the third session of our breastfeeding series, which is on understanding dynamics of production to intake of breast milk. In our previous sessions, we examined the crucial roles of breastfeeding in safeguarding maternal and child health and explored the various benefits and essential nutrients that breastfeeding provides. Today, we will take an in-depth look at the intricate processes involved in breastfeeding, from the physiological mechanisms of milk production to the factors influencing effective intake by the infant. This session aims to deepen our understanding of how these dynamics work together to support the health and well-being of both mother and child. First, we need to understand the anatomy of the breast. At the center, you can see the nipple surrounded by the darker area known as the alveola. The alveola contains small glands called Montgomery's glands, which secrete an oily fluid to keep the skin clean and lubricated. Inside the breast, there are numerous tiny sacs called alveoli, which are responsible for producing milk. Although the diagram shows only a few alveoli, there are millions of these structures. The box on the diagram highlights three enlarged alveoli. Milk production is stimulated by the hormone prolactin, which acts on the cells in the alveoli. Surrounding the alveoli are muscle cells that contract to help push the milk out. The hormone oxytocin triggers these muscle cells to contract during breastfeeding. The milk travels from the alveoli through small tubes called ducts. These ducts merge into 7 to 10 larger ducts that lead to the nipple. Milk is stored in the alveoli and small ducts between feeds. During a feed, these larger ducts beneath the areola, called lactiferous sinuses, expand to temporarily hold the breast milk. The secretory alveoli and ducts are surrounded by supporting tissue and fat, which shapes the breast and account for the differences in the breast size. Despite differences in the breast size, both small and large breasts contain a similar amount of glandular tissue and can produce an adequate supply of milk. Before we proceed, let me first explain the stages of lactation. Mammogenesis. This is the process of the mammary gland's growth and development in preparation for milk production. It begins at puberty when the mammary gland is exposed to estrogen and is completed during the third trimester of pregnancy. Then comes lactogenesis. Mammogenesis is followed by lactogenesis, which involves the development of ability to produce and secrete milk. During lactogenesis, the alveolar cells in the mammary gland mature, enabling milk secretion. Lactogenesis occurs in three stages, which we will be discussing shortly. Involution. Involution is the final stage of lactation where the changes in the mammary gland regress after lactation ends, returning to the state close to pre-pregnancy. Involution occurs about 40 days after the complete cessation of breastfeeding. The longer the duration of breastfeeding, the longer this process takes. As already said, lactogenesis, which takes place in three stages, is the process of developing the ability to secrete milk and involves the maturation of alveolar cells in the breast. Stage 1 of lactogenesis is also referred to as secretory initiation. This stage takes place during the second half of pregnancy. The placenta supplies high levels of progesterone, which inhibits further differentiation. By week 16 of gestation, small amounts of milk can be secreted. By late pregnancy, some women can express colostrum. This stage is under endocrine control. Stage 2 lactogenesis. This is also called secretory activation. The removal of the placenta at delivery results in a rapid drop in progesterone and increased levels of prolactin, cortisol, and insulin, which stimulate this stage. It occurs between 30 and 72 hours following the delivery of placenta. Mothers typically begin feeling breast fullness around 50 to 72 hours after birth. This stage is under autocrine or local control. Lactogenesis 2 is maintained by nipple stimulation and regular milk removal from the breast. Usually on day 2 or 3 postpartum, most women experience breast swelling along with increased milk production. In primiparous women, the secretory activation stage is slightly delayed and early milk volume is lower. Lactogenesis 3 is also called galactopoiesis. This is the stage of copious milk production which starts later than 9 days after birth and remains up to beginning of emulsion. This is the maintenance phase of lactation and is dependent on autocrine or local control. Before we discuss the hormones that play a crucial role in lactation, we should have a fair idea about the pituitary gland which secretes these hormones. Pituitary gland is a small, pea-sized endocrine gland located at the base of the brain below the hypothalamus. It is made up of two distinct regions called the anterior lobe and the posterior lobe, which are functionally active. The lactotrophic cells in the anterior pituitary secretes polypeptide hormone prolactin, also known as lactotrophin. It is structurally similar to growth hormone and placental lactogen. Prolactin is regulated positively and negatively, but its main control comes from hypothalamic inhibitory factors like dopamine, which act on the D2 class of dopamine receptor in lactotropes. Prolactin plays a crucial role in stimulating mammary gland ductal growth, epithelial cell proliferation, and milk protein synthesis. The posterior pituitary gland secretes oxytocin hormone, which is another key hormone in lactation. Oxytocin is produced in the hypothalamus but stored and secreted into the bloodstream by posterior pituitary gland. Oxytocin hormone is responsible for the milk ejection reflex. It causes the muscles around the alveoli in the mammary gland to contract, pushing the milk into the duct and towards the nipple. This hormone is essential for the effective release of milk during breastfeeding. Let's explore how breast milk is produced. As the baby suckles on the breast, it provides a sensory stimulus through the nerve endings in the nipple to the anterior pituitary gland situated in the brain, resulting in the release of hormone called prolactin. This hormone acts on the gland in the breast for milk production. Thus, milk production is dependent on the suckling stimulus. That is, more the baby suckles, more prolactin will be secreted and hence more milk will be produced. Prolactin follows a natural secretion schedule with the highest levels occurring at the night due to its circadian rhythm. Therefore, nighttime breastfeeding is especially helpful for maintaining milk supply. Prolactin also has a relaxing and sleep-inducing effects on mothers, allowing them to rest well even when breastfeeding during night. Suckling influences the release of various pituitary hormones such as gonadotropin releasing hormone, follicle stimulating hormone, and luteinizing hormone, leading to the suppression of ovulation and menstruation. Consequently, frequent breastfeeding can aid in delaying a new pregnancy. Ensuring nighttime feeding is crucial for maintaining this effect. Having understood the prolactin reflex, let's now move on to discuss the oxytocin reflex. Oxytocin starts working when a mother expects a feed as well as when the baby is suckling. The reflex becomes conditioned to the mother's sensations and feelings such as touching, smelling, or seeing the baby, or hearing her baby cry, or thinking lovingly about him or her. When a baby suckles, sensory impulses go from the nipple to the brain. In response, the pituitary gland at the base of the brain secretes the hormone oxytocin. Oxytocin goes in the blood to the breast and makes the muscle cells around the alveoli contract. This makes the milk that has collected in the alveoli flow along the ducts to the larger ducts beneath the areola. Here the milk is stored temporarily during the feed. This is called oxytocin reflex or the milk ejection reflex or the letdown reflex. As the reflex works, the larger ducts beneath the areola fill with milk and increase in size. Sometimes the milk flows to the outside. Oxytocin is necessary to enable the baby to get the milk. If a mother is in severe pain or emotionally upset, the oxytocin reflex may become inhibited and her milk may suddenly stop flowing well. Oxytocin makes the mother's uterus contract after delivery and helps to reduce bleeding. The contractions can cause severe uterine pain when a baby suckles during the first few days. With the knowledge we have gained about the factors which help or hinder oxytocin reflex, it would be better if a mother keeps her baby close to her all the time to see, touch, and respond to them. This proximity will help her body get ready for breastfeeding and encourage the flow of breast milk. If there is a separation between the mother and baby between feeds, it can disrupt her oxytocin reflex, making it harder for the milk to flow. When speaking with a mother, we should always consider her emotions. We should aim to uplift her spirits and boost her confidence as this supports the smooth flow of her breast milk. Avoid any comment that might create doubts about her milk supply. The oxytocin reflex plays a crucial role in breastfeeding. Recognizing these signs of an active oxytocin reflex can help ensure that breastfeeding is effective and that the baby is getting enough milk. A mother may observe or experience sensations in the breast. A mother may feel a squeezing or tingling sensation in her breast just before she feeds her baby or during a feed. This is the body's way of signaling that milk is ready to be released. Milk may start to flow from the breast when a mother thinks of her baby or hears him cry. This reflexive response is triggered by the hormone oxytocin, which is often stimulated by the thought or sound of the baby. When the baby is suckling on one breast, milk might drip from the other breast. This is a common occurrence and indicates that the oxytocin reflex is active in both the breasts. Milk streams during feeding. When the baby comes off the breast during a feed, the mother might see milk flowing from her breast in fine streams. This shows that milk is being released effectively. During the first week of breastfeeding, a mother might experience pain from uterine contractions, sometimes accompanied by a rush of blood. These contractions are stimulated by oxytocin and help the uterus return to its pre-pregnancy state. Last but not the least, slow, deep sucks and swallowing by the baby indicate that the breast milk is flowing well into the baby's mouth. This is a positive sign that the oxytocin reflex is working effectively. Breast milk production is also managed within the breast itself. It's fascinating to understand why sometimes one breast stops producing milk while the other continues, despite both receiving equal amounts of oxytocin and prolactin. The diagram explains that a component in breast milk can inhibit further milk production if a large amount of milk remains in the breast. This inhibitor halts further secretion of milk, protecting the breast from becoming overly full. This is crucial if a baby dies or stops breastfeeding for any reason. When milk is removed through suckling or expression, the inhibitor is also removed, allowing the breast to produce more milk. This explains why one breast stops producing milk when a baby stops suckling from it. The breast that is frequently suckled produces more milk and becomes larger than the other. So we understand that continuous milk removal from the breast ensures ongoing production. Milk must be expressed to maintain production when a baby cannot suckle from one or both breasts. This local control of breast milk production becomes particularly important after the first few weeks when prolactin level decrease. To understand the suckling process, it's important to know about the reflexes in babies that facilitate this action. These reflexes occur automatically in response to certain stimuli. There are three main reflexes directly involved in suckling: the rooting reflex, the sucking reflex, and the swallowing reflex. The rooting reflex occurs when something touches a baby's lips or cheek. The baby responds by opening their mouth and turning their head to find the object, while moving their tongue down and forward. Ideally, the baby is searching for the breast. The sucking reflex is triggered when something touches the baby's palate, prompting the baby to start sucking. The swallowing reflex happens when the baby's mouth fills with milk, leading to swallowing. Now, these reflexes are innate and do not require the baby to learn them. Babies are also born with other reflexes, like the gag reflex. That is, when the baby, in response to something touching the anterior part of the tongue, pushes it out. There are some other reflexes, like babies often bring their hands to their mouths and massage the mother's breast. Additionally, when placed on the mother's abdomen or chest, babies make stepping and crawling movements to reach the breast for suckling. Similarly, mothers also have a natural instinct to hold their babies to the breast. Holding the baby close and facing the breast stimulates the baby's reflexes, aiding in proper attachment. For many mothers and babies, this process occurs easily and naturally, as most healthy full-term infants can instinctively latch onto the breast. It's essential to keep the mothers and baby together in a comfortable, supportive environment that promotes these reflexes. Mothers need to learn how to avoid uncomfortable positions and holding techniques that might inhibit the reflexes. Similarly, healthcare workers should refrain from intervening if everything is progressing well, but should be attentive to mothers who need assistance. This could be due to various reasons, or if the mother is in an uncomfortable position hindering the process. Some babies might need more help than others to learn how to latch and suckle effectively. Before we move on to latching, let's take a closer look at the process involving feeding reflexes. Ideally, the baby should approach with the nose opposite the nipple, as you can see in the illustration here. This positioning helps the babies to latch on properly because the nipple aims towards the baby's palate, stimulating the sucking reflex. The baby's lower lip is positioned well below the nipple, allowing the tongue to get under the larger milk ducts. Now the next movement is to quickly move the baby to the breast with the aim that the baby's lower lip is below the nipple. Baby will then start suckling with good signs of attachment. It's important to know what constitutes good and poor attachment. Now this diagram illustrates how a baby properly latches onto the breast to nurse. Notice the following: that while suckling, the baby has taken a substantial portion of the areola and the underlying tissues into their mouth, and the larger milk ducts are encompassed within these tissues. The baby has extended the breast tissue to form a long teat, and the nipple constitutes only about one third of this teat. The baby is nursing from the breast, not just the nipple. Regarding the baby's tongue position, the baby's tongue is forward, over the lower gums, and beneath the larger ducts. The tongue cups around the teat of breast tissue, which may not be visible in the drawing but can be observed when watching a baby nurse. The tongue presses milk out of the larger ducts into the baby's mouth. When a baby takes the breast in this manner, they are well attached, making it easy to extract breast milk. resulting in effective suckling and ensures that the baby's mouth and tongue do not rub against the breast and nipple skin. As the baby suckles, the following occurs. A wave-like motion travels along the baby's tongue from front to back, pressing the teeth against the baby's hard palate. This action squeezes milk from the larger duct into the baby's mouth, where it is swallowed. Thus, the baby does not merely suck milk out like through a straw. Instead, the baby uses suction to stretch the breast tissue, forming a teat and holding it in their mouth. The oxytocin reflex triggers milk flow, filling the ducts beneath the areola. The tongue's action presses the milk from the ducts into the baby's mouth. When a baby is well attached, they can efficiently remove breast milk, leading to effective suckling. Often you can see and hear a baby swallowing when they are nursing effectively. Let's analyze these pictures which show signs of good attachment. More of the areola above the baby's upper lip is seen as compared to the areola seen below the lower lip. This shows that the baby is reaching with his tongue under the larger ducts to press out the milk. It is also seen that the mouth of the baby is wide open and the lower lip is turned outwards. The chin of the baby is touching the breast. These are some of the signs that indicate that the baby is well attached to the breast. It is to be noted that visibility of areola above the upper lip is not a reliable sign of poor attachment because some mothers have a very large areola and a lot of it could be visible above the upper lip even if the baby is well attached. It is more reliable to compare how much areola is visible above the baby's upper lip and below the lower lip. Now let's have a closer look at the baby which is poorly attached. In this picture, you can see that almost same amount of areola is visible above the upper lip and below the lower lip, which shows that the baby is not reaching enough for the larger ducts. Mouth is not wide open and points forward. Lower lip is not turned outwards and the chin of the baby is not touching the breast. And now if you have a closer look, just see that it is only the nipple which is in the baby's mouth. In the previous slide, we identified the signs of poor attachment. It is also observed that during poor attachment, the baby is nipple sucking as there is no underlying breast tissue in the baby's mouth. As a result, the baby cannot reach the larger ducts with the tongue because they are outside the baby's mouth. Additionally, the baby's tongue is far too back to press on the larger ducts. All of this leads to ineffective suckling. We will now understand the consequences or the potential outcomes of a baby being poorly attached to the breast. When a baby is poorly attached and nipple sucks vigorously to obtain milk, causes the nipple to be pulled in and out, resulting in friction between the nipple skin and the baby's mouth. Persistent sucking in this manner damages the underlying nipple, which can be very painful for the mother, often leading to sore nipples. Suction pressure at the nipple tip can create fissures there, while rubbing at the base can cause fissures around the base. the baby is unable to effectively remove the breast milk. Ineffective removal of breast milk due to poor attachment, referred to as ineffective suckling, can lead to several issues which we will see in the next slide. If a baby is poorly attached, they do not remove breast milk effectively. The breast may become engorged. The way that the baby suckles is called ineffective suckling. This can further result in cascade of problems if not taken care of. The baby may be unsatisfied because the breast milk comes out slowly. The baby may cry a lot and want to feed often or for a very long time at each feed. The baby may not get enough breast milk. The baby may be so frustrated that they refuse to feed altogether. The baby may fail to gain weight, so poor attachment can be a cause of slow growth. If the oxytocin reflex works well, the baby may get enough breast milk at least for a few weeks by feeding quite often, but it can exhaust the mother. So poor attachment can make it seem as though a mother is not producing enough milk. Moreover, the breast may make less milk because the milk is not removed. In other words, the mother has an apparent poor milk supply. If the situation continues, her breast may really make less milk. In either situation, the result may be poor weight gain in her baby and breastfeeding failure. To prevent this happen, all mothers need skilled help to position and attach their babies. Now here's a word of caution. Babies should not be given feeding bottles. If a baby feeds from bottle before breastfeeding is established, they may have difficulty suckling effectively. Even babies who start bottle feeds after a few weeks may also begin to suckle ineffectively. In the previous slide, we discussed about the result of poor attachment. Let us now discuss what are the causes of poor attachment. Now, use of feeding bottle is a well established to hinder a baby's ability to suckle effectively from the breast, especially when bottle feeding is introduced before breastfeeding. Even babies who switch to bottle feeds after a few weeks might also start to suckle ineffectively. Use of pacifier in the initial weeks is also known to interfere with breastfeeding. Inexperienced mother is another reason for poor attachment. A first-time mother or a mother who had challenges breastfeeding previous babies might struggle with proper attachment. Mothers may also be in a rush or lack the patience to ensure that the baby is well attached. Various functional difficulties can also make it challenging for a baby to attach to the breast. Delay in initiating breastfeeding, especially if there is no skin-to-skin contact immediately after birth. Babies who are very small or weak, mothers with nipples that are difficult to protect, stretch out to form a teat, and gorge breasts in mothers. Now, another significant reason for poor attachment is the absence of skilled help and support. Some mothers might be isolated and lack community support or assistance from experienced individuals like their mothers or traditional birth attendants. In cultures where bottle feeding is common, women might not be familiar with breastfeeding techniques and practices. Healthcare providers such as doctors, nurses, and midwives might lack adequate training or time to support breastfeeding mothers effectively. Despite these challenges, with skilled assistance, mothers and babies can successfully breastfeed, which we will be discussing in later sessions. Before we wind up this session, let's summarize what we learned from this session, breastfeeding, understanding dynamics of production and intake. Breastfeeding relies on the hormonal interplay of prolactin and oxytocin stimulated by the baby's suckling to produce and release milk. Ensuring a proper latch is crucial for effective breastfeeding and to prevent issues such as nipple pain and poor milk transfer. Regular and frequent breastfeeding sessions are essential to maintain and regulate the milk supply. Mothers benefit from skilled support and education on breastfeeding techniques to overcome potential challenges. In session 3 on breastfeeding, understanding dynamics of production and intake, we understood the physiological and hormonal processes involved in breastfeeding and the importance of proper latch and frequent feeding to maintain milk supply. In session 4, breastfeeding, perfecting the art of positioning and effective latching, we will understand how to position the child to breast for effective latching while breastfeeding. We invite you to share your thoughts, questions, or any topics you will like us to cover in future sessions. Please feel free to reach out to us via email at rajendra_gulati @hotmail.com. Your feedback and input are invaluable to us as we strive to create informative and helpful content. Thank you for joining us and looking forward to continuing this journey together. Have a wonderful time.